Hi, I'm Dr. Tony Mork, endoscopic spine specialist. Today, I'd like to talk about spondylolisthesis. And although there are 5 types of spondylolisthesis as described by Wiltsey, Newman, and McNabb, I'd like to talk about the most common one I get to see in my practice, which is degenerative spondylolisthesis. Well, first off, what's a spondylolisthesis? Spondylo means spine, and olisthesis means to slip. So there's some slipping of one vertebrae on the other. In this case, usually in the elderly population, although not always, and 6 times more commonly at the L4-5 level than the other levels above or below, is a facet degenerative problem. And as the facets joints, as the joints of the facets narrow, the vertebrae can actually slip forward. So let's take a look on this model about what I'm trying to explain. Well, in this model here, we can see that we're looking at the spine from the back, and this is a facet joint here. If I turn that a little bit obliquely, you can see that there would normally be a joint here with several millimeters of cartilage between the 2 facet joints. So if I take them apart, you can see that the bones from the facet joints are going to meet like that. Each of these is covered with articular cartilage, and if there was wear and tear and the cartilage is gone, you can see that the actual vertebrae could slip forward. So in the picture here, what I've drawn is the facet joints in the back wearing out, and as a result, this vertebrae, let's just say 4, 5, can slip forward. As a result, the disc oftentimes will narrow, the joint will become arthritic, lose its joint space, and the body, in response to this whole thing, will oftentimes try to form osteophytes and calcify spinal ligaments in order to reduce the motion, particularly at the level where the most motion occurs, which is L4-5. Let's take a look in real life on an MRI scan what I'm talking about. This is L3 and 4, and what we see is the L3 vertebrae moving forward just ever so slightly. And we can see that it's gone forward here. Hardly ever is there more than 30% slipping of one vertebrae on top of the other in a degenerative spondylolisthesis, because we're just talking about the joints wearing out. There's no fracture or disruption of the ring that allows the vertebrae to move forward any more than that. Let's take a look at the axial slices and see what happens in this particular situation. Remember, we're looking at the axial slice, so we're looking down the spinal canal here. In this case, we've got the vertebral body and disc, the very arthritic and overgrown facet joints. The white is a little bit of fluid left over, much worse on the right side here than the left. The black stripes here are thickened, and in this case, somewhat calcified ligamentum flavum. As a result, the spinal cord is compressed here, which is resulting in pain and radicular leg symptoms, in particular leg symptoms of pain and numbness. So we have a situation where the degenerative changes, the facets, the overgrowth of bone and calcification of ligaments has encroached in the spinal canal and compressed the spinal cord, giving rise to his back pain and radicular leg and buttock symptoms. Treatment for this in the younger people with a lot of motion at L4-5 may require a fusion. However, the vast majority of people I get to see are the elderly, and these are people whose long-term spondylolisthesis of a degenerative nature have required the body to throw down some osteophytes, try to calcify the ligaments, and thus almost, or at least try to perform an autofusion of sorts, meaning that the motion is kind of out of the segment, and these people are perfect candidates for an endoscopic spinal decompression without the use of a fusion. Well, thanks a lot for listening. I hope you enjoyed this talk about degenerative spondylolisthesis. If you've got any further questions, please look at my website, drtonymork.com, or don't hesitate to give the office a call and discuss your situation. Thanks a lot.